Hello, my name's Dr Karen Chumbley and I'm a GP and I'm the clinical lead for Suffolk and North East Essex for end-of-life care. And I'm recording this session today to talk about the launch of the ReSPECT process across Suffolk and North East Essex that's taking place in March this year. ReSPECT stands for the Recommended Summary Plan for Emergency Care and Treatment, and it empowers patients to make decisions about their future care. So the aim of today's session is to increase awareness and confidence with the new ReSPECT process and the documentation that we're launching on the 1st of March 2023 across the whole of Suffolk and North East Essex in replacement of the East of England Do Not Attempt CPR form. This decision was taken by system partners via the Integrated Care System End-of-Life Group, which has a broad base of representation of the major health and social care organisations across the area. So why would we launch this at a time of significant pressure on the healthcare system? Well, the reason for that is there's never been a more important time to ask people what's important to them for their future care and to create a plan for that care and to share it with colleagues to inform future decision making. For too long, Do Not Attempt CPR discussions have been isolated from a wider discussion about the type of care that is important to that person. They don't have a chance currently to inform aspects of their care, such as whether they want to be admitted to hospital or receive antibiotics or treatment intensive care unit. There's been no system for recording of all of that data in one form that can follow the person as they move through the healthcare system. The broader ReSPECT process supports a wider discussion about priorities within the diagnostic and social context of the person that will further inform our healthcare colleagues who are making decisions in an emergency situation if the person is unable to represent their own wishes at the time. The ReSPECT process creates a personalised recommendation plan for their clinical care and treatment in a future emergency. These recommendations are created through conversations between the person and their families and the health and care professionals to create a shared understanding of what matters to them and what is realistic in terms of their care and treatment. Patient preferences and clinical recommendations are discussed and recorded on a non-legally binding form, which can be reviewed and adapted if circumstances changed. The ReSPECT process was launched in 2016 and has been implemented widely across England, and in East of England has already been launched in Cambridgeshire and Norfolk. So this is our plan. We will launch the ReSPECT process and form on the 1st of March 2023. There's already been widespread education around the ReSPECT process across Suffolk and North East Essex, and that will continue throughout the spring. There will be a gradual phasing out of the Do Not Attempt CPR forms over time. There is not an expectation that everybody who has a DNA CPR form in place will immediately have that replaced by a ReSPECT form. But as people are educated about the ReSPECT process and healthcare professionals are competent to use the ReSPECT form and process, there will be a phasing out of the DNA CPR form and a replacement with the ReSPECT form. These ReSPECT forms are complementary to other forms of advanced care planning recording, such as the My Care Choices Register in North East Essex or the My Care Wishes documentation. Advanced care planning more widely encompasses people's plans for their care, but also what they want to achieve more widely than that, what's important to them as regards their family, as regards their place of care, and their social and spiritual wishes. The ReSPECT form concentrates on medical decisions, so sits within a wider advanced care planning discussion. We're doing this because national guidance recommends that discussions about CPR should not be held in an isolated fashion away from a discussion about a wider holistic treatment escalation plan. I'm not going to show this video over this webinar session today, but this, if you are interested, is a very straightforward video that explains the ReSPECT process, and you can use this to share with your wider healthcare team to explain what's involved in a ReSPECT conversation. So what is a ReSPECT conversation? A ReSPECT conversation is about reaching a shared understanding of the person's condition. Often people will not understand fully the implications of a diagnosis, and this is an opportunity to come to a mutual understanding about the condition and its impact on the person. And then within that shared understanding, developing and identifying preferences for future emergency care. For example, when I'm working in the care homes where our practice is aligned to, I'll often have discussions with people and their families about what they would want to happen should they develop a pneumonia, or should they have a fall. Would they find hospital care acceptable to them? Would they want to have oxygen, intravenous antibiotics, fluids, or other aspects of care? The ReSPECT process allows us to record an agreed focus of care. For many people, that's about living as long as possible, but for others, perhaps towards the end of their lives, their focus may be on comfort care. And so this gives us a chance to discuss with our patients what their priorities are so that care can be coordinated around them. Then the form gives us an opportunity to record these shared decisions about specific forms of treatment, and it also includes a section to document a recommendation about CPR, cardiopulmonary resuscitation, and whether that should be offered in the event of a cardiac arrest. You may wish to learn more about this process, and here is a web address of a learning application that is straightforward. It only takes about half an hour and it covers the basics of the ReSPECT process. And you may want to share this link with colleagues that will also be involved in this process within your service. As well as these sessions and other webinars that we're offering over the spring, each healthcare organisation will be offering training to their staff. We want to offer that in different levels because the level of understanding of ReSPECT that's required varies depending on people's roles. Level 1 is when somebody just needs to be aware as part of their role of what a ReSPECT form is. Level 2 is for a ReSPECT reader. These are people who need to be able to understand the information on the ReSPECT form and act upon it, often in an emergency. And level 3 training is for those who will be having the ReSPECT conversations and documenting the results of those conversations onto the form. This level 3 training will be offered in 2 different ways. There will be a relatively short offer of training for people who already complete do not attempt CPR forms, because they have already received the training about those advanced care planning conversations, and they just need to be updated as far as the new ReSPECT process and documentation. And for people that are new to ReSPECT conversations and documentation completely and have previously not taken part in any resuscitation conversations and documentation, there will be a longer level 3 training offer in order that they can be skilled up in these conversations with their patients. So this is a copy of the ReSPECT form. So in an emergency, we'll be looking for a mauve copy of the form. This replaces the red do not attempt CPR form that we use currently. If somebody has a DNA CPR form in place in an emergency, then that remains valid. If two forms are found, then we should review the most recently completed form. Somebody ongoing should not have different copies of forms in their record. The previous forms should be cancelled, leaving one contemporaneous plan. I'm going to now talk you through the ReSPECT form so that you can see how it's put together. So it begins in much the same way as a do not attempt CPR form, with the patient's details at the top. Then there is a section for documentation of the shared understanding of the person's health and their condition. This is also the place to record if somebody has a wider advanced care plan, for example, on My Care Choices or a My Care Wishes folder, or an advanced decision to refuse treatment. It is useful to say where this documentation is recorded so that it can be accessed in an emergency. There's also a space here where a lasting power of attorney can be recorded so that a healthcare person dealing with somebody in an emergency can be aware of the person that has been authorised to speak on the patient's behalf. There's then an important area of the form where the person can document what matters to them in decisions about their treatment and care in an emergency. This is a chance for people to record what they most value and what they most fear and want to avoid, and to give some sense of where their priorities are between living as long as possible and quality of life and comfort. For many people, they want to hold both of those in equal priority, and that's completely reasonable. But this is an opportunity for somebody to share with their healthcare professional the relative importance of those two issues for them and how they want them to be held in importance in a future emergency. And then underneath that section, there is an area for the clinical recommendations. So this is an area to be completed by the clinician, and they sign whether we are prioritising extending life in an emergency, balancing with comfort care, or prioritising comfort. And then there's an area for specific guidance on particular interventions that may or may not be warranted in a future emergency situation. It is hoped that this documents interventions and decisions, recommendations that are agreed between the person and their clinician. If there is disagreement, then a second opinion should be sought. It's not possible for somebody to demand treatment that a clinician feels is not going to be helpful for them, but it's important to explore their understanding and see if a consensus can be reached, if not escalated to a senior healthcare professional or to a colleague for a second opinion. At the bottom of the front page of the form, there is an area for recording about a recommendation for cardiopulmonary resuscitation. And it's important that in an emergency situation, the form is looked at to see the details of that decision, rather than just assuming because they have a form perhaps that they're not for CPR. It is extremely important that people realise that it can be documented on this form that there is a recommendation for CPR. On the back of the form, there is an area where the mental capacity and the involvement of the person themselves in writing this plan can be recorded. It's important for us to reflect and consider whether this person has capacity. In the absence of mental capacity, can we still get information from that person as to inform our decisions? And also whether a proxy, a lasting power of attorney, has informed this decision making. This next section is where it is recorded who has been involved in these recommendations and decision making, whether the person had mental capacity or whether they were represented by a lasting power of attorney or a family member. There's also a section to record who has been involved in the decision making when the person involved is less than 18 years old. If there's no option selected from these above, then reasons must be recorded. It's absolutely vital that these discussions involve the person, and where they do not have capacity, it involves people close to them. If there is no one to represent the person at all, no relevant family or friends or representation, then independent advocacy should be considered. Underneath, there's an area for clinician signatures. It will be for organisations to decide how they wish to structure the decision and signatures on these forms within their framework. For example, in primary care, it would be completely appropriate for only the GP or perhaps a senior nurse responsible for that patient to sign the form. Within hospitals, it may well be that junior healthcare professionals sign in the first instance, but within the framework of the organisation, it's recommended that perhaps a senior clinician, such as a consultant, may countersign to show that they're in support of the decisions made. Please refer to your own internal organisational policy for that. And here we have a section where the emergency contacts for the person can be recorded, their role and relationship to the person and their contact number. And there's also an option for them to sign the form to show that they've been involved with this decision making. This signature is optional. The form is valid without signatures of the emergency contact, but it does give another opportunity to show engagement with this decision making. And then at the end of the form, there's a section for review. It's important that this conversation is ongoing and these decisions are reviewed regularly, perhaps when the person moves into hospital or out from hospital, or when there's a significant change in their condition. If there is a significant change in the decisions and recommendations made on the form should be cancelled. It should be scored through and clearly marked as cancelled and a new form written. But if there are only minor changes or adaptations, then the form can be reviewed and signed by the updating clinician. So here are some frequently asked questions. What is the difference between a do not attempt CPR form and a ReSPECT form? Well, I think I've covered that earlier on. A do not attempt CPR form is only about CPR. It doesn't involve other decisions about other care, and indeed should not inform decisions about other care, such as admission to hospital. ReSPECT allows the documentation of a wider medical plan. Should a GP contact a patient or relative only to talk about resuscitation? We wouldn't recommend this. This would be a very jarring conversation if it was done in isolation of the discussion about their condition and a wider advanced care plan. The following question is, should a relative be asked to make a decision about resuscitation status of a patient? It's important when discussing this with family members that they don't feel the burden that they are making this decision on behalf of their relative or loved one. This is a clinical recommendation made by clinicians for future to inform the practice of future clinicians. It's always important to be clear that that responsibility sits with the clinician, and what we're seeking to do by having the conversation is to hear the voice of the family and of the patient themselves within this decision making, but the responsibility stays with the clinician. Can I have a ReSPECT conversation over the phone and then post it to them? This is possible, although I think these conversations are important. They are emotive and they're best held face to face. And I would really be only using a telephone consultation for this if it was not possible to have a face-to-face consultation. And we've talked about updating a ReSPECT form and how that would be done, and that it would be signed under the review section at the back of the form, although if there's a significant change, the form should be cancelled, clearly written through and a new one created. Can a ReSPECT form be photocopied? There's an important issue around version control of ReSPECT forms. If they're photocopied, it's not clear if that's the most recent copy of a ReSPECT form. So we recommend that they're not photocopied for clinical use. They can be photocopied for sharing information to inform, for example, when attached to a discharge summary, the actual copy of the ReSPECT form should move with the patient into the community and remain in their home. But you may wish to use a photocopy only for that initial information that a ReSPECT form has been shared. It should be clearly marked as copy and not for clinical use when the original form should be used. GP surgeries or organisations will receive ReSPECT forms from the project launch team, but once launched, each organisation will be responsible for providing their own supply of ReSPECT forms and will be circulating a PDF copy that can be used to print out those forms. The difference between a ReSPECT form and an advanced decision to refuse treatment is mainly around their legal standing. An advanced decision to refuse treatment is a legal document, whereas a ReSPECT form is a documentation of guidance for a future clinician. So therefore, ReSPECT forms are not legally binding. They are there to inform and guide, but do not have their own legal standing. And we've talked already about the need to sign the form, that it can be useful, but is not absolutely necessary. So thank you very much for your time. Here are the contact details of myself and Juliet Estel, who is the project manager for the ReSPECT project launch. Thank you.